Now it's time for our next presenter, Dr. Bukstein, who is going to present to us on building an asthma lifestyle plan, the total lung connection to improve asthma outcomes. Just touch on a little bit about Dr. Bukstein's background, and you can also read Dr. Bukstein's full bio in your event pamphlet. Dr. Bukstein is our keynote speaker for today. He's triple board certified in allergy, immunology, pediatric pulmonary, and general pediatrics, and has really quite a long and rich history of leadership experience in healthcare and health systems, as well as some enrichment in the humanities, going back to education in English literature, and then pursuing a healthcare and health leadership path. So Dr. Bukstein, the floor is yours.
Hello, everyone. This is Dr. Bukstein here in Wisconsin. Let me see if I can get my slides up here. Okay, hopefully everyone can hear me. I want to thank the sponsors of the Florida Coalition for Asthma sincerely in giving me this opportunity to talk about something that is near and dear to my heart, and that is building an asthma lifestyle plan and what we call the total lung connection at the Allergy and Asthma Network, patient advocacy group for patients with asthma and their families. If we could have the next slide. These are my conflict of interests. I do research for a number of different pharmaceutical companies, and I am president of the Problem-Based Learning Institute, where we teach doctors how to teach, as well as serving as medical director for the advocacy group Allergy Asthma Network. Next slide. Today, what I'd like to do is set the stage for the rest of the conference. And whoever put the conference together, I applaud, because they start out with what is definitely the most underutilized part of our ability to control asthma, as well as other chronic diseases, and emphasize the importance of lifestyle change. I've never liked the word action plan. I think it's always a lifestyle plan that we make with our patients, or should make with our patients and their families, and trying to manage their asthma. Today, we're going to talk about that, and we're going to describe another passion of mine, shared decision-making approach to lifestyle change that maybe you can incorporate into your daily practice. I certainly hope so. You can begin to understand why sleep, exercise, nutrition, stress control are all important, as well as environmental factor control as much as possible to create a robust lifestyle plan. Next slide, please. Well, I'm going to add to my disclaimer. I don't think any pharmaceutical companies would pay me for giving a lifestyle lecture. And I'm not going to be talking about any off-label kinds of things. What could be off-label about a lifestyle change anyway? But next slide. I do want to talk about asthma management and how a lifestyle plan can be the centerpiece to really good asthma management. When asthma and allergy patients think about managing their systems, they instantly think about medications. And that's what a lot of physicians, clinicians, nurse practitioners, physicians' assistants think about managing asthma. I just throw in a medication, patient should be controlled. I think they need to take, and we need to take, a broader view of health and consider lifestyle factors that can impact their breathing in general and their asthma. Next slide. If you look at what contributes to premature death, you're going to see the huge, big slice of this pie that was elaborated in a wonderful New England Journal article quite a few years ago, is that behaviors account for the widest proportion of premature deaths. And that is equally, if not more true with asthma. Next slide. We have far too many deaths, and the deaths occur in minority populations that are underserved. And that's a big challenge for all of us to meet today, to understand the really huge problem we have with asthma disparities. Next slide, please. If we take the whole body approach, we can really act as a team to really approach that in every single patient and hopefully avoid deaths. Next slide. As we move toward a healthy lifestyle, we really want to emphasize those lifestyle changes that we know from research, and a huge amount of research. I'll go through a few of the studies in exercise, sleep, nutrition, stress management, and avoidance of environmental factors. All are important as we approach that lifestyle change. Next slide. I think a really interesting quote is that of recently in a really another very, very good study that said an action plan process is agreeing on small change with high probability of success and may convert some pre-contemplative patients into action stage. What we want to do is activate our patients. The best way to activate patients to consider cultural competency, asthma disparities, and literacy is through action plans that are really lifestyle plans that take into account all those factors as they do that with the patient through shared decision making. Next slide. So what we want is not a acute care asthma action plan, what to do when you get sick and how do you get to the ER. What we want is to talk about diet, exercise, sleep, stress reduction, anxiety reduction, depression, response to increased symptoms, how to get to the quality of life you want and access to better care. Next slide. That's the action plan we really want. And we want to share education and communication tools in achieving this wellness. And again, share decision-making with the patient, hopefully using a well-validated shared decision-making aid so you don't miss anything, is really important in using it with traditional medical education, self-management, motivational interviewing, coaching, a whole range of things to really empower patients to be successful with lifestyle change. Next slide. We use the 5 A's that were developed with smoking cessation to really summarize what needs to be discussed and really acted upon. And that's access, make sure the patient has access, advise in a clear and personalized way, hopefully using shared decision-making with agreeing on collaboratively selecting goals and the methods you're going to achieve those goals, and assisting the patient in gaining those skills and arranging follow-up. Very important. One of the things that gets missed a lot is synchronizing refills. A simple thing that you can do in the pharmacy is synchronize all their refills so they get them at the same time, will help significantly with adherence. Next slide. So what are the top 5 reasons doctors, clinicians, nurse practitioners, physicians, assistants don't practice behavioral medicine lifestyle change? Well, they say they don't have the skills. They don't believe it's important. They don't get paid for it. Takes too much time, and believe the patient cannot and will not change. All of these could not be further from the truth. Next slide. Most often, it's the physician or the clinician that really needs to get their act together and plan a little bit better to incorporate a wellness approach. Certainly, it is very cost effective. And when you consider indirect costs, lifestyle change is really cost effective in promoting better health, not only to asthma, but across the board into almost all chronic diseases, as well as just general health. Next slide. So it's not about being the best, it's about being good, okay? It's not about cost, it's about the value, what kind of quality you can get for cost. So it's really quality over cost. It's not about therapy versus placebo, it's about the benefits and burden of therapy versus the burden of not using therapy. And each person has to weigh those individually through really good shared decision making. It's not simply about whether it's worth it or not, it's about whom it's worth it to. And is the patient going to benefit in the ways that they want to benefit from whatever you're doing, especially with lifestyle change. Next slide. Just 45 minutes a day of structured exercise. I tell my patients that's all it takes. You just need a diet that's reasonably low in glycemic index. You just need to monitor portion size and avoid inactivity. Those are my suggestions, and they're based on many, many studies, including Weight Watchers, Successful Losers. But it goes beyond that. I try to practice what I preach, and it's not easy. And I tell the patient it's not easy, and I mess up myself all the time, and don't adhere totally to my diet or my exercise or my portion size or my inactivity. But I try each day to improve on that. And you need to really empower your patients to do that too. Next slide. Diet. What is the importance of diet and lifestyle change? Well, it's hugely important. Obesity is a huge risk factor in asthma, and there are many, many studies that show that approaching obesity, even with a small weight loss of 5 to 10 pounds, can mean a lot with improved asthma control. Antioxidants, they can be replaced. There's some data that that's useful. Pre and probiotics, watch this space, and bacterial extracts. I think there's going to be more and more about their benefit, especially in allergic types of asthma. Smoking, I don't need to really elaborate on that. Breathing techniques, underutilized form of asthma control and lifestyle. I think we had someone at the beginning of the program going over some exercises and breathing techniques that improve your ability to stay focused. And I think those are important. There are Botemko and other kinds of breathing techniques that have been around for many, many years that are also very, very useful. Approaching psychologic variables such as depression and exercise have all proven in many studies to be effective lifestyle change in promoting asthma care. Next slide. Nutrition and asthma. I don't think we have all the data we need on antioxidants and PUVAs and their importance in better asthma control. But in general health, there is a great deal of data, the importance of a good diet. Mediterranean or DASH type diet may be the best, but really making sure you have adequate nutrients, vitamin E, vitamin D, PUVAs, and not just during pregnancy, but at other other life times that these nutrients are available. Many of our patients live in areas where they don't have good access to nutrition. And that is such an important aspect of better asthma control. I think I'll maybe talk about that a little bit later, but there is some data that supplements of vitamins and nutrients don't add to asthma control if they're adequate. But many of our patients, those nutrients are not adequate, so supplementation may be useful in those patients. Next slide. Again, I can't estimate the importance of nutrition. Many of our patients have suboptimal intake, especially of things like vitamin D. We typically find very low vitamin D levels in the inner city population, especially in young kids that aren't outside exercising every day, but kept home and inside because of their asthma. There are studies in chronic lung disease and COPD and asthma showing benefits of fruits, vegetables, other antioxidant rich food, including fish. I'll show you one study. And increased diet in these foods can help improve lung function in many patients. Next slide. Here's a study that looks at antioxidants. AO is high antioxidants, and you have a Kaplan-Meier survival curve, and you can see the improvement from low antioxidants to high antioxidants, better survival probability. Next slide. Mind-body therapies. I know a lot of people poo-poo and say, oh, how can yoga or Tai Chi or other mind-body therapies help? But the data is accumulating that these types of therapies are anti-inflammatory. And many inflammatory processes are triggered by autonomic nervous systems, which of course emotions are key to controlling that. Stress reduction, anxiety reduction, understanding depression, and getting proper therapy and support is key to really making sure that lifestyle change is adequate. Next slide. Stress reduction is also key. I think we don't understand, especially in some of our inner city population, the severe stressors that they're under. And especially in children and teenage years, peer pressure, homework, all kinds of things can add to the stress of that individual patient. Here, we're understanding those factors through better shared decision-making may help alleviate some of those stressors. Next slide. One of the things that we do is give a depression screen to all our patients with significant asthma. And I think a 3-question or a PHQ-9, 9-question depression screen is well worthwhile. And there are several studies to show that, in fact, depression is very, very common, and treating that depression improves asthma control. And again, breathing exercises, including yoga, relaxation techniques, all been shown to be helpful. Next slide. And should you limit asthma activity, especially in children? And the resounding answer is absolutely not. 3 in 5 patients limit their activity because of their asthma. Next slide. One of my mentors said that he had a family, and the mother asked what could she do to improve the child's asthma on an ongoing basis. And he replied, exercise, exercise, exercise. That little girl ended up winning 4 gold medals in swimming in the Olympics. So exercise can help improve asthma control. There's accumulating data that different types of exercises may be more beneficial than the other, but exercises can improve asthma control. Next slide. There are other benefits to exercise. It helps with weight loss. It's not the answer to weight loss. You're not going to exercise yourself into weight loss, but it certainly helps with all chronic conditions, improve mood, muscle tone, boosts energy, promotes sleep. Next slide. Sleep. Important. Asthmatics have a higher incidence of obesity associated with their asthma. That adds to sleep problems through airway obstruction. And just in general, asthma, well, the nighttime doesn't belong to Budweiser, it really belongs to asthma. Asthma is a disease of the night, and oftentimes that's when people struggle and they don't get enough sleep, and that plays a huge role in lung health. Next slide. The obesity adds to the asthma and to the sleep disruption, which again feeds back and makes asthma control that much harder. Environmental factors. We've done studies in the inner city in Milwaukee that show that environmental factors, dust mite control and avoidance, cigarette smoke avoidance, even passive smoke, and your asthma allergy triggers, since most asthma is a T2 or allergic type of asthma, not only adjusting to the right medications, but really knowing what your triggers are and trying to avoid them. Next slide. Approach to patient empowerment. This may be one of the most important. You need to build relationships. Next slide. The build on this one. Collaborate. Next. Educate. Negotiate. And those can be done very, very effectively in using small groups. You can do them individually through shared decision making, but you can also do it with small group therapy, which tends to be very effective in weight reduction, exercise, and other aspects of lifestyle change and understanding nutrition. Next slide. So, shared decision making, something I'm passionate about. This is something that's not done as often as it should be, but it's something that's been around for many, many decades. It's probably the underlying concept of control of disease. Way back with Osler, one of the most famous physicians of the 19th and 20th century, the validated shared decision-making aids weren't around, but what he said was we need to sit down with our patients and make a shared decision, engage them, and needs to be a standardized approach. And this is where shared decision-making aids that are well validated can really help us, and helping that patient understand their preferences and choose what's best for them. Next slide. Next slide. Okay, what is shared decision making? Well, it's when you sit down with the patient, or your staff sits down with the patient and helps them make an informed decision that's best for them, understanding the benefits and harms and understanding their preferences. Next slide. It's molding not only your perspective, but the patient's perspective. In For a patient, it's all about sleep and disruptive symptoms to their life and their daily life, going to work and how much it costs. Next slide. To the doctor, it's maybe controlling their asthma, objective parameters, whether they're adherent, and cost too, and the bother factor that keeps them coming back to the doctor, which is often comorbidities, allergic and non-allergic rhinitis, and the other comorbidities of asthma. Together, a doctor and patient can make a shared decision making that'll improve adherence, patient satisfaction, and improve asthma outcomes. Next slide. Shared decision making is not a one and done process. If well done, it involves trained staff using a shared decision making aid if possible, if one exists for your patient. And there are some shared decision making aids out there for asthma and better ones on the way. Your patient needs to have a plan. From a shared decision-making point of view, they really need to incorporate their desires into that plan, okay? And again, that really will improve your patient satisfaction and adherence to their plan and medication. Also, another outcome is it decreases malpractice risk, and recent study in Washington State. And that's understandable if both of you agree on a specific action or lifestyle plan. And shared decision making is even more important in lifestyle plans, because there you're really changing the patient's lifestyle, and that's not easy to do. And you really may do that in little steps that both you or your staff and the patient agree on. Next slide. One thing next slide, I think as we move to the end, and we can see me up on the screen, I guess. As we move to the end, I want to really emphasize that you can put all this together in a very simple way. If you identify asthma disparities, you understand the role of shared decision making, and you go through that process of lifestyle change with regard to smoking status. I haven't talked about, but inhaler technique really is kind of part of that shared decision of what kind of inhalers they want and how they're going to use them. How you're going to monitor the patient is really a shared decision. And pharmacotherapy. In this day and age, moving to biologic therapy with many pros and cons and many choices, shared decision making is very important. Lifestyle change, very important, as this whole last 30, 40 minutes we've been talking about lifestyle change really demands shared decision making. And shared decision making really is part of the education process. And you can incorporate education that's appropriate for that patient. They understand with aspects of cultural competency and literacy that are really intertwined with shared decision making. And finally, figure out how you can support them. If they're depressed, if they're anxious, if they're stressed, that support and that support system that you really develop through shared decision making with the patient can be important to really realize lifestyle change and better asthma outcomes that we're all after. So I think we have a little time, Ted, don't we, for some question and answers?
We do. I'll let Zan moderate Q&A here.
Okay.
For folks, if you have any questions, feel free to drop those in the chat on the event page now, and we'll be able to get them all asked for Dr. Bukstein.
Great. Let me just refresh my chat to make sure I'm seeing everybody's current comments. And if you put a question in the event chat, I will read it out for everyone aloud so that Dr. Bukstein can give an answer aloud, as well as in the chat. Folks who are just joining us, there's also some really good information coming through in the chat about how to make sure that you get your CE credits. And I believe that's Carolina Alcala from the Florida Asthma Coalition Management Health Council of Southeast Florida, sharing that information. All right, so I'm going to be watching the chat for questions that come in. Dr. Bukstein, thank you for that terrific presentation. That was a lot of great information, and I really appreciate that you left some time for direct interaction. While folks are thinking of questions, I see a question has come in on our speaker chat that might be good for Dr. Bukstein to answer for the group. I see a question from Dr. Weiss asking, how do you deal with barriers to a holistic lifestyle approach to asthma management? Terrific question.
Yeah, it is, and it's not an easy one. I think you have to incorporate it into your daily practice, and there's no way that an individual clinician can do it all. And so really it is a team effort with your support staff. And I'm not the best one actually in my office to do good shared decision making. I'm not the most empathetic. And initially, that shared decision making process is initiated by me, but is incorporated into one of my nurses who really is from the population that I serve in the inner city of Milwaukee. understands a lot of the problems she's faced herself and really can empathize with the patient. Then I come back in at the end, answer questions, and really kind of sew up that shared decision-making process. The process that we use is establishing misinformation initially, and then offering choices, providing options, eliciting preferences, and then most importantly, talking about next steps, what we're going to do if this lifestyle plan doesn't work well, how can we adjust it? So it's not a one and done process, it's something that's ongoing, but it takes your whole staff.
Terrific. I'm watching the event chat for other questions that folks would like Dr. Bukstein to answer. And I see some, oh wait, I see a question has come in on the event chat. Where can we find evidence-based decision aids?
That is a great question. I became so frustrated that in the field of allergy, asthma, pulmonary, there weren't enough shared decision-making aids that were well validated, that I've joined with a small company that develops shared decision-making aids, especially for patient advocacy groups. And we've developed and we're working in vaccine hesitancy to a great degree right now in both children and adults. But we've done hereditary angioedema, urticaria, and we're working on asthma tools as we speak for both children and adults that are validated. There is an asthma tool that I helped create that's not been well validated and is a little out of date, but it resides in Allergy Asthma Network and on the CHEST website, and happy to send those links. But really, I think individual practices can kind of create their own shared decision-making aids with a little bit of knowledge and a little bit of work, but the validated ones are coming for asthma. And I think the Florida Coalition will certainly be aware of when those are made available.
And I see we also had a question come in for Dr. Dunham. So Wanda, if you are here with us and you would like to activate your camera and your mic to answer, please feel free to do that. What did Dr. Rodriguez Dunham mean by current asthma? Is that a current flare? I was always taught that once asthma was diagnosed by a medical provider using breathing tests, there is no cure. Oh, and I see Dr. Dunham has put an answer in the chat. Current asthma means that the person still has asthma. And then we have another question that came in. What if the patient is deferential to the provider and does not want to engage in shared decision-making, as in just wants the provider to make the decision? So Dr. Bukstein, what do you think about that?
That's a common misconception that a great percentage of our patients don't want to be involved in this decision. There are about 10% of patients that do not and can't be coerced or in any way encouraged to participate. But it's only 10%. 90% of patients, whether it's oncology with cancer, whether it's rheumatology with types of arthritis, whatever the chronic disease, want to be part of the process. They really say nothing for me without me. And they want to be part of the process. Now, they may have different roles in that process, and that's why training and shared decision-making is really important. But really, most people do want to be part of the process. And I think we need to respect them when they refuse, but it can be offered multiple times. And I think almost all my patients, maybe a little less than 1 in 10, say, no, I don't want to be part of the process. They all want their preferences to be understood and the decision to be one that both parties make.
So I'll jump in here a little bit also and say, as someone who spends a lot of time being a respiratory patient, and that's a lifelong thing, multiple ways to give your feedback are also really important. And this is where, that idea about it's not just about the participation overall, but it's really about the values and preferences of each unique patient and the pathways by which they came to those values and preferences, culture, socialization, gender norms, lots of different things that influence our behavior, as well as just personality. Some people are quieter. Some people maybe don't speak aloud, or might benefit from being able to write their feedback, or to have an interpreter present if there's language but they're more comfortable speaking, and even if they do speak English. I see another comment coming in the chat. So we had another follow-up on the question about current versus lifetime asthma. And making that distinction between curing and controlling, which is an important distinction. Then we have a question saying, slightly off topic, but as a nurse epidemiologist during COVID, we did not see patients with asthma having significantly poorer outcomes than the general population, unlike chronic obstructive pulmonary disease. In fact, at one point, we heard on a webinar that there was a possibility of asthma actually having a protective quality regarding COVID. Thoughts?
I could approach that one. Yeah, it's really quite interesting that with COPD, there's no question there was a signal of increased morbidity and even mortality with active COVID. But with asthma, especially well-controlled asthma, okay, and that is a factor because poorly controlled asthma tended to have significant problems with COVID, but well-controlled asthma really didn't seem to be a risk factor, and there was a slight benefit, and that may be because they were taking inhaled corticosteroids. There are other theories. I don't think we know for sure, but it is well known that asthma and allergies are not a significant risk factor if well controlled to COVID morbidity or mortality. So an interesting factor.
Yeah, we saw this in the cystic fibrosis community as well,
Yeah.
and it really speaks to the diversity of what we experience.
Yeah.
Just like asthma is a general cluster of health issues, so are most global chronic conditions. And what individual people experience may be very different, but there may also be some common threads like recurrent respiratory infections, very common in asthma, very common in CF. That might mean you're less likely to have kind of this shock and awe immune response, that cytokine storm we were seeing information about.
Yeah, I mean, that is an interesting theory, and I think one of the prevailing theories, but COVID has presented some opportunities also because I just published an article this month in Allergy Proceedings about the effect of telemedicine. And that may be why ER visits and other things went down, is because we had this huge opportunity. And within the underserved community, it's important to take advantage of those opportunities. We find that shared decision-making, lifestyle change, small group therapy can be, if coordinated properly, done through virtual means and bring groups together virtually and make access better for some parts of the population. So again, taking the good of telemedicine and trying to understand the problems is the way to go. And hopefully we'll keep it reimbursed for now.
Absolutely. And we're seeing this theme of just choices expanding, how to participate in your own care, how to participate in events, and what conversations to have.
And lifestyle change is all about choices, offering them to the patient, offering support to the patient. I have a handout on exercise, a handout on diet, and then we go, my nurse goes over it and says what they're willing to do. And it's just like smoking cessation, small steps. And having that support there.
All right, let me check my event chat again. I'm not seeing other questions coming in the speaker chat. We've got a question about certificates of completion for asthma educators who took, I believe that references the mini course. And then I also see, I do see another comment in the speaker chat as well from Dr. Weiss, which I will read out in just a minute. So for our mini course attendees, make sure that you fill out any documentation needed for your CE credits. I believe that our Altus and Health Council reps can put some information in the event chat about certificates of completion specifically. Then we have a comment, and Dr. Weiss, thank you for bringing that to my attention. Dr. Weiss says in the speaker chat, I teach nutrition and applaud your emphasis on healthy eating, especially ingesting more fruits and vegetables. I've helped to establish an organic garden, so physical activity as well as getting access to produce on the grounds of an African-American church and across the street from Department of Housing and Urban Development, or HUD, housing in Palm Beach County. Children get instructions on nutrition and learn to garden. They keep all the produce they sow in their planting bed. Such initiatives help deal with food deserts in poor urban areas and a lack of resources to buy fresh produce. Absolutely, absolutely. And community gardens, I mean, I'm a sociologist, so community gardens are so much more than just access to those foods, in addition to the benefits that you get from eating fresh foods and being able to explore what fresh foods you like best. I mean, gardening together, moving your body, being outside, getting fresh air, these are all things that are incredibly nurturing for our health.
These are solving that access problem that is so prevalent and accounts for asthma disparities in some part. And I applaud these kind of endeavors because they really do give the opportunities. But again, it's going to take you sitting down or your staff with the patient and them understanding them and agreeing to and developing that shared decision kind of contract with the patient to move forward.
Absolutely. And we have time for one more question. I do see one more question in the event chat. Since time is such a barrier in consultation, in your experience, do decision aids make consultations take longer? Should providers give patients educational materials outside of the consultation to keep appointments on time?
Oh man, what a great question. There's lots of research and they do take a little longer. If you use a validated shared decision-making aid, it depends on if your staff's using it and if you're looking at your time, but total time of the visit is longer, but less than 5 minutes, okay? And there are codes for obesity management and other types of management that exist that really behoove you to understand so that when appropriate, there can be charges made and you get reimbursed for your time. Reimbursement can be based on time. And if it takes you a little bit longer, then you have to change maybe the way you're coding. But yes, it takes a little bit longer, but it's well worth it. If you look at total time with the patient over many encounters, you'll see that the time is actually shortened because you spend less time with acute care. You're spending more time preventatively, okay? And prevention is always the best time saver, most efficient, and most cost effective.
Fantastic. All right. So I believe that it's time to transition over to our next speaker who has a 9:35 start time. Oh, yes, go ahead, Dr. Bukstein.
No, I just want to thank everybody. I want to thank you and the rest of the Asthma Coalition for this excellent opportunity. And please go forward with all the excellent endeavors that Florida Coalition has taken to really improve asthma care. Thank you all.